Good afternoon, everyone. We're going to do it one more time. I know it's after lunch. Shake it off. Deep breath. We can do it. Good afternoon, everyone. Yes. Thank you for coming back. For those I haven't met yet or who are just joining us, my name is Dr. Aditi Mallick. I am an Indian American woman, dark skin, dark hair. I'm wearing a purple suit with a white shirt. And for those who were here yesterday, same silver shoes. Thank you for coming back. We have a really exciting session today. I personally am so thrilled and honored to be on this stage with so many beloved colleagues. This session is really going to be focused on how CMS is integrating health equity really into the DNA of what we do day in and day out in our programs and our policies. We're going to focus today on access, affordability, and quality. And as I said, I really am just so thrilled to be joined by my colleagues from across CMS. In 2021, we started by agreeing to a common CMS definition of health equity, and we've built on that collaboration really each step of the way. You'll hear that collaboration really reflected in all of the remarks that folks will share today. But briefly, I want to share with you what that definition is that we use at CMS to help ground today's conversation. To CMS, health equity means the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. From our work on definitions, measures, access standards, payment policy, and other areas, we've really learned from each other and with each other and included each other and built off of existing work. I personally can attest that each person on this stage is really an integral part of advancing health equity across CMS programs, and we're all committed to taking bold action together to ensure that health equity is sustainably embedded in our programs and our policies for years and decades to come. We're going to dig in now to hear exactly what's going on in each of our programs and what that means for health equity. I realize I have not yet introduced the esteemed folks on stage, so as we go through the question, what I'll do is introduce who each of these wonderful colleagues are and where they sit within the agency to give you a sense of how the work all ties together. So first question really for everyone is, what is your center or office strategy or planned approach to health equity? And hoping everyone can share 2 to 3 recent or major highlights that you want to highlight for the audience here that you think will have the biggest impact. So I'll start all the way to my left with Dr. Dora Hughes, who's the acting director for the CMS Center for Clinical Standards and Quality and the acting chief medical officer for the agency. Dora.
Thank you. And I just want to start by thanking you for putting this panel together and giving a shout out for a wonderful day 2 of the second Health Equity Conference. Certainly for us, many of us participating, it's just been an amazing series of panelists and speakers and an opportunity for us to listen and learn. And it's also wonderful to connect and see so many of our colleagues and friends, our external partners upon whom we rely very closely. Again, my name is Dora Hughes. My pronouns are she and her. I'm an African-American woman in a black suit, a coral top with curly hair that reflects that it rained earlier this week. Many of you'll know what I mean by that. In terms of, for those of you that may not be familiar with the Center for Clinical Standards and Quality, or CCSQ, I like to say we are the second largest center at CMS, and we have primary responsibility for establishing national clinical quality and safety standards for all across all settings, from healthcare, such as hospitals, post-acute care settings, such as skilled nursing facilities, to long-term care, including nursing homes. And we do that in a variety of ways. First, we're the lead on the quality enterprise. We develop and implement quality measures through 20 quality reporting and payment programs. We also establish rules and requirements for Medicare and Medicaid providers that want to participate through our conditions of participation. We sponsor the QIO program, which provides in-depth technical assistance on the ground across hospitals, providers. And we also have a very robust survey and certification team to ensure compliance with our requirements, which is one way of providing accountability externally and to us. That we are doing all that we can, again, to advance quality, safety, and equity. I wanted just to share a few highlights of the work that we do that over this past 12 months that we are especially proud of. The first, I'll just start, since I mentioned we're the lead on the quality measured enterprise at CMS. Starting last year, and within the last year, we started collecting data. We have a health equity structural measure where we're asking hospitals participating in one of our quality reporting programs, what is your commitment to health equity? Are you collecting data? Are you using the data? What's your governance structure? Is equity a stated priority? As one example, we are also, by the end of the year, we will have required screening for social determinants of health across our programs, wanting our facilities to screen for transportation needs or housing instability or the need for food assistance and so forth. That's another. We are also starting to provide quality reports back to providers stratified by race, ethnicity, increasing other socio-demographic variables, and so that providers themselves can see how they're doing and adjust their own performance as necessary. Another example, and just a couple of months ago, we released a nursing home minimum staffing standard rule. As many of you know, within nursing homes, staffing, the level of staffing is the quality indicator. That's the level of staffing is most closely tied to how nursing homes will perform on quality. And yet, despite this, we know that for many nursing homes, the level of staffing is not where it should be to provide needed care for residents. And so in April of this year, we released a final rule where we have established the minimum level. We have a total nursing staffing standard of 3.48 hours per resident per day. Then that is inclusive of 0.55 hours per resident day of registered nurse care, 2.45 hours for nursing aides per resident per day. We are also requiring there to be a registered nurse on site 24 hours a day, 7 days a week. And we know that this has special relevance in the equity context because those nursing homes that serve a disproportionate number of Black residents, for example, provide the lowest quality of care. They have the worst outcomes, and in many ways, having adequate numbers of staffing can address the deficiencies that we are more likely to find in these nursing homes. Certainly, we recognize coming out of the PhD, of course, that there are workforce challenges and there are exemptions built into the rule, particularly for those facilities in rural areas. There's also a staggered timeline, implementation for all, but an even longer timeline for those in rural areas. But again, we are quite focused on improving staffing in nursing homes, again, to make sure that residents are getting the care that they need. And the final example that I will provide is in the context of maternal health, and I would be remiss if I didn't point out my colleague Jean Moody Williams, who's somewhere in this room, has really led much of our work in maternity. Oh, she's in the back corner. She waved her hand there. But we have finalized two measures for within the context of maternity care. One is looking at the rate of severe obstetric complications. For example, did the pregnant women did they experience sepsis or hemorrhage or preeclampsia, those types of very severe complications, which, as all of you know, can have a severe impact on the outcomes for the for the mom and the infant. A second one is looking at the rates of cesarean deliveries for low-risk women as another quality indicator. And then last year, we also rolled out our birthing-friendly designation, and it asks hospitals participating in one of our quality reporting programs 2 questions. The first is, are you participating in a statewide or national perinatal quality collaborative? And the second question is, are you implementing any of the interventions, the reforms, the safety bundles that you're learning from participating in the collaborative? And if you're able to attest to both of those, if you are answering yes to both of those questions, then you are eligible for a birthing-friendly icon. This is something that we will be posting or working with health plans to post as a way to really help pregnant women, birthing people to identify which hospitals are in many cases best suited for their needs, where they can get the care that they need. And so certainly we're proud of the first step, and we will certainly moving forward be looking to think about ways that we could strengthen the birthing-friendly designation even more, working with internally with our colleagues within CMS, other federal agencies, CDC, HRSA, but also thinking or looking, listening, learning from so many of our external partners on next steps in this space. And so more to come certainly with that. And so I think you said 2 examples. I think I gave 3. So I'm going to stop there. And again, appreciate the time to share some of our work at CCSQ.
Thank you, Dora. I'm going to go a little bit out of order here, and I'm going to turn to Dr. Jessica Lee, the Acting Chief Medical Officer for Medicaid and CHIP. Jess, anything you want to add on birthing-friendly or maternal health collaboration?
Absolutely, yeah. So first of all, hi, great to be with you, and thank you so much for allowing us the chance to share some of the activities that we're doing today. I'm Jessica Lee, and I identify as a multiracial woman of Asian American descent, and I'm wearing a green blazer with long, dark hair. It's always good to take a second to remember what you're wearing while you're doing this. It's been really exciting to see the collaboration that's happened across CMS, and to experience the collaboration happening across CMS, particularly some of the initiatives like the Birthing Friendly Initiative and a new model that's happening in the Innovation Center. In the Medicaid and CHIP space, I'd like to start also, I would be remiss if I did not call out my colleagues who lead our maternal health work. My colleague Ellen Marie Whalen, and also Kristen Zeicherman and Deirdre Stockman, who are here with us, and also speaking later today, so tune in for more. But we've really laid out a robust quality improvement initiative, multi-pronged initiative to support work with states to improve maternal health. Improving health equity is a cornerstone of everything we do, and there's nowhere where that's more true than in the space of maternal health. Among some of our upcoming activities are 2 new affinity groups that we're starting with webinars and then launching into these multi-state affinity groups where we support states doing quality improvement projects in 2 categories. The first being supporting behavioral health needs for individuals who are pregnant and in the postpartum period, and also improving hypertension control and cardiovascular health. So those are 2 of the upcoming things that are happening in the maternal health space, and I think really align well among the many things that are happening here. I think also, I'll talk more about this a bit later, but access to care is really foundational to everything that we do. And we have been so excited to see that 46 states plus the District of Columbia and the U.S. Virgin Islands have taken up the opportunity to provide up to 12 months, to provide a full 12 months of comprehensive postpartum care coverage. Yeah.
Thanks, Jess. Thanks, Dora. I'm going to go back to the original question of sharing some of your center's approaches to health equity and any recent examples that you would like to highlight. So next up, Dr. Liz Fowler, Deputy Administrator and Director for the CMS Innovation Center, also known as the Center for Medicare and Medicaid Innovation, or CMMI, if you can track the government alphabet soup. Liz, over to you.
Thank you so much, Aditi, and everyone on the panel. It's always fun to be on a panel with my colleagues and be able to share what we're doing. So the CMS Innovation Center was created to test new approaches to care delivery and care improvement. How do we improve the health system for patients so that they have a better care experience, and also for providers? How can we align financial incentives? So we have done a number of things. First, let me tell you a little bit more about the strategy, and I will give credit to Dr. Dora Hughes, who was our Chief Medical Officer and actually developed and launched the strategy when she was still at the Innovation Center. We have 4 prongs. First of all, we're actively looking for ways of incorporating new innovation strategies into our models that reduce health disparities. I'll just give you one example. In our ACO REACH model, we're testing whether giving a bonus payment to providers or organizations who enroll a higher proportion of underserved patients can actually improve access. And so for for organizations, or ACOs in this case, who are going into those communities, who are enrolling beneficiaries or working with and serving those beneficiaries, they get a bump in a payment. We're also requiring for every model now, starting since 2021, providers and participants in our models must develop a health equity plan. So tell us what disparities exist in your patient population and what you're going to do to address those disparities. The second thing is we're trying to make sure that all of our innovations reach as far and wide as they can. So how do we enroll more safety net providers and, again, reach those populations who haven't been privy to and benefited from some of the innovations we've been testing? So we have a model that looked at creating a specific track for FQHCs, for Federally Qualified Health Center, for CHCs to enroll in the program, giving them extra funding, incentives, resources to be able to participate in the model. We hadn't done that in the past, and we're finding that we have more than doubled the safety net participation in our models since launching this strategy. The third thing is the evaluations. When I came on board, I asked the question, have we reduced health disparities and in our models? And the answer was we don't know, because we weren't collecting the data and the evaluations weren't really designed to determine whether we were doing anything about disparities. And so now all of our evaluations are designed up front with an explicit goal of trying to figure out whether we're actually advancing health equity. And I think that's really important, because otherwise we're not going to know whether we're successful in the other aspects of the model. And then finally, we're doing data collection, making sure that our models are collecting data on race and ethnicity, on health-related social needs, on geography, underserved populations, SOGI data. And did I describe the strategy right that you put into place?
You did pretty good.
Okay, thanks. So again, I give Dora credit. And then you heard yesterday from Dr. Purva Rowell, our Chief Strategy Officer, and she's carrying the baton now and implementing a lot of these. So I'll talk a little bit about just a couple examples of how we're also trying to design models that really touch and reach historically disadvantaged populations, marginalized populations. We recently announced a model focused on cell and gene therapy access for sickle cell disease. So very expensive strategies. How do we get those therapies in the hands of patients and really generate those better outcomes that we think these therapies can potentially provide? And so that model will start January 1st, 2025 in as many states as decide to sign up, assuming we have manufacturers coming to the table and agreeing to those outcome-based payment arrangements. The second, also in maternal health, and I think that's a common theme you'll hear across the panel today, we have a maternal health model that we're getting ready to put out a notice of funding opportunity for states to join that looks at really whole person care. Can we come up with a payment model that really leans into whole person care, that takes care of expecting parents starting from pregnancy to childbirth to postpartum, and considers social needs as well as mental health needs and physical needs? And then also we just recently announced a model focused on kidney transplant. How can we make sure that there's equal access to kidney transplants for all populations when we look at the disparities between who gets kidneys, who's on the waiting list? We want to try to see if we can do something about that. And so I didn't also, before I end, I just want to say I identify pronouns she and her, and I am also half Asian. I have that in common with Jessica, and I'm wearing blue pants and a nondescript colored jacket.
Thank you, Liz. Perfect segue to Dr. Meena Seshamani, our Deputy Administrator and Director for the Center for Medicare. Meena, same question to you of your team, your and your team's approach to health equity and some examples that you might want to share.
Great, thank you. And I'll echo, it's wonderful to be here with such esteemed colleagues on stage and with all of you. So I'm Meena Seshamani, pronouns are she, her. I'm an Indian American woman wearing a black dress and a green blazer. So in the Center for Medicare, we approach equity in two ways. Probably the way, akin to what everyone has been talking about are specific policies that we can put in place to address the disparities that exist and ensure that people have a fair and just opportunity to achieve their optimal health. But importantly, our center also runs the operations for the Medicare program, and equity is part of every single thing we do in the program, because when the healthcare system is broken, is difficult to navigate, doesn't work for people, the ones who are more likely to fall through the cracks are those with complex social needs, those with complex medical conditions, those who don't have family supports, don't speak English. So, the first example that I would give you is actually just our routine oversight that we do. Early on when I took on this role, we had a really tragic situation through our oversight of health plans where we found that there was a gentleman who had gone to an ophthalmologist. The referral loop was not closed with the primary care provider, which was required, and he ended up losing his vision. And this was, significant oversight that we did, that we had to impose, civil monetary penalties. And, the team always, in everything we do, when they put together briefing memos, the end is, what is the health equity impact? And what was the health equity impact here? The team said, well, this isn't a specific policy around equity. This is just what we do every day. And I said, well, what language does the patient speak? He was Spanish speaking, didn't speak English. Did he have any family supports? He didn't have any family supports. And I think that's just an example of how when things aren't working well in the system, that in and of itself can worsen disparities. And by trying to make the system work better and keep people at the center of it, that will also help with the disparities that we have in advanced health equity. Aside from our day-to-day operations, we have absolutely also been working on policies to really address the issues around inequities. And, some examples there, first, as Dr. Hughes mentioned, the requirements around social needs screenings. In the Center for Medicare, we have our payment lever. And so for the first time ever in the Medicare program, we are paying for social needs screenings. But beyond that, we are paying for community health services. And we are paying for care navigation for people who have serious illness. And we're also paying for caregiver training, right? So that we can really make sure we all know that 80% of our health is determined outside of that office visit with that ICD-10 code and that E&M code. And we're really trying to make sure that we are supporting care where it is needed and how it is provided. And importantly, those services can also be provided by peer recovery coaches, not just community health workers, social workers, so that we really are embracing the full scope of what it means to take care of people. Also, I'm going to piggyback off of something that Dr. Hughes talked about with quality, where we are now rewarding excellent care for underserved populations. So in Medicare Advantage, in our Star Ratings program, and in the Medicare Shared Savings Program, the largest accountable care organization program in the country, for healthcare providers or plans who are caring for underserved populations, if they meet quality metrics, they get an additional bonus. So thereby rewarding providing excellent care in those communities that oftentimes have fallen through the cracks. So I think that is a second example of where we're really trying to embed equity into the policies of our program. And I think a third example, which may not come to life for people, come to the top of the mind, we also run graduate medical education. And one of the big issues in health equity is lack of access to healthcare providers. So thanks to congressional action, we were given the opportunity to roll out 1,000 new GME slots, 200 a year over 5 years. And we have prioritized rural and underserved areas for those slots because we know that when people train in communities, they learn the needs of those communities, and they're more likely to stay in practice when they're done with their training. So far, we have rolled out 400 slots. The majority are in primary care and behavioral health. And we also have the good fortune now of being able to roll out an additional 200 slots specifically in behavioral health. And we have a proposal out for that now. So again, using every lever that we have to try to address the needs of our communities. And that workforce provision goes hand in hand with another significant change we made to the Medicare program, where now licensed marriage and family therapists and licensed mental health counselors, including addiction counselors, can enroll in the Medicare program. There are roughly 400,000 such clinicians out there who could not directly see Medicare beneficiaries. And it has been incredible. In the first month alone, this started in January, that people could enroll. They were already asking to enroll last quarter of last year. And we already have like more than 10,000. In the first month, we had more than 10,000 new clinicians enroll. So again, when you look at rural communities, when you look at underserved communities, they don't necessarily have access to a psychiatrist. And being able to have other types of clinicians in a team-based approach be able to provide care to people in the Medicare program is really key to addressing some of the issues that have faced our communities. With that, I'll turn it back to you, Aditi.
Thanks, Meena. I think reflecting on what's been said so far, this real theme of intentionality, right? An intentionality around reaching people where they are and designing policies that we hope will meet people where they are, and listening in the process to know whether it's working, right? To be tracking the data, whether it's health-related social needs data, race, ethnicity data, or just qualitative feedback like what we hear from you all in forums like this to help know if we're paddling in the right direction. And I think we're really hearing that come through. Next, I'm going to turn it to Tim Engelhardt, Director of the Medicare and Medicaid Coordination Office, also affectionately known as the Duals Office.
Because we focus on the 12 or 13 million people who are dually enrolled in Medicare and Medicaid. And now Meena focused on Medicare. And the Medicare program has been this tremendous force for good for almost 60 years right now. Except it's kind of expensive. It's got premiums and cost sharing that a lot of older adults and people with disabilities struggle to cover, right? And so there's good news. The good news is that we have subsidy programs that make Medicare more affordable for people for low incomes. You didn't even mention the fact that the Inflation Reduction Act significantly made the low-income subsidy more generous to cover Part D drugs. So we have Part D low-income subsidy. We also have these things called the Medicare savings programs. And these are actually like Medicaid eligibility groups through which the state Medicaid agency covers your Part B premiums and in many cases your Medicare cost sharing, right? Some of you know these as like QIMBY and SLIMBY and these other like Medicaid eligibility terms, right? So that's the good news. The bad news is that these are all like undersubscribed, right? There are millions of people who are eligible to enroll in the low-income subsidy for their Part D coverage or these Medicare savings programs who haven't yet enrolled. And so what that means is that probably for some of those people, they choose not to initiate treatment that they need, right? Because they're worried about costs that they can't otherwise afford, right? And for all of those people, they're paying what is right now like $175 a month in Part B premiums, right, to cover just to be enrolled in Medicare. So that's money. That adds up. It's thousands of dollars a year for people who are at or near the poverty line just to be enrolled. And that's money that could otherwise be going to food and transportation among those dually eligible individuals. We just did the Medicare Current Beneficiary Survey. 45% of them are food insecure. So $175 a month goes a really long way, right? So undersubscribed. And if we could just get another million people into these programs, that's $175 a month in their Social Security checks that they can use to cover food, that they can use to improve their access to services, that they can use to age with more independence and dignity. And we can do all of that without even inventing entirely new programs. We can just do it by doing a great job of executing on the programs that already exist today. Now, we're excited. I'm just only going to talk about one thing I'm really excited about because I don't want to water it down. We finalized some new federal regulations last fall that will make it easier for people to enroll in these Medicare savings programs. It'll do it in a couple different ways. First, by better leveraging data from the Social Security Administration to enroll people automatically, or at least with less effort, into the Medicare savings programs. We'll also do it by taking some of the other friction out of the application process for those who need to apply. And literally, it will remove literally millions of hours of red tape and burden for older adults and people with disabilities who need help to afford their Medicare coverage. And if we do it right, it'll be another million people with better access to medical care and better economic security.
Thank you so much, Tim. Really speaks to that idea of, the title for this panel for folks that read it was really about access, affordability, and quality. And I think you're hearing those themes resonated, right? That it's one thing to make sure that people can even get in the door of healthcare coverage and have the privilege and the peace of mind. It shouldn't be a privilege. In this country it is. But the peace of mind of carrying an insurance card in their pocket, and then when they have that card, that it offers meaningful access to healthcare. I'm going to turn it to you, Jess. Same question that we started with, but full introduction again, Dr. Jessica Lee, Acting Chief Medical Officer for the CMS Center for Medicaid and CHIP Services.
Thanks so much. Also, I'm amazed that we managed to put duals between Medicare and Medicaid. That was just incredible coordination there.
Shocking that someone thought to do that.
I'm so impressed. This is such an incredible topic. I can and have spent an entire hour talking about this. So I'm just going to highlight a few things that in the Medicaid and CHIP space we've been doing to really make huge strides in health equity. And I think about this in a couple of ways, just like going off of the doors and opening doors idea, both in terms of creating doors of access to healthcare, but also creating doors wherever people are. So in terms of, thinking about bringing people into care, we've done a number of different things in terms of rulemaking in the last year, especially. We've taken lessons learned from the process of unwinding as people went through the experience of having to renew their coverage for often the first time in as long as 3 years in the setting of the continuous eligibility requirements during the public health emergency. So we've taken lessons about, pain points, what makes it difficult. Things like if you give people more time to fill out paperwork, they're more likely to be able to keep their insurance. We've seen that from states who have taken up options like that. And we've taken those lessons learned and we put them into packages of policy like our eligibility and enrollment rule that released earlier this spring. Also in terms of technical assistance, in terms of guidance that we've been putting out to help our state partners, because we're really committed to keeping all of the people who are eligible enrolled in Medicaid and CHIP, and for those who are no longer eligible, supporting them in transitioning to other forms of insurance like marketplace or employer-sponsored coverage. So those are some foundational things. We've also issued recently, just last month, rules improving access and on improving managed care access, finance, and quality. And so, thinking about this again in the spectrum of bringing more people into care and bringing more care to people, these rules are just foundational in terms of creating accountability and oversight, but also just new national standards in terms of what plans and states have to do to make sure that their beneficiaries are getting access to the services they need and that those services are high quality. So a couple examples of that, and from the managed care rule, for example, are that the managed care rule created for the first time national maximum wait times for specific services. And so that's just a foundational thing, again, in terms of thinking about improving access to services like primary care services, OB services, and behavioral health services. Another example is the quality rating system that was created in the managed care rule. And that's a system by which it is going to empower beneficiaries to give them the information they need to choose the health plans that are the best fits for them. I'm thinking, beyond access, thinking about kind of creating more doors for people, meeting people where they are. We've also created new opportunities for states to provide access in different kinds of settings, whether it's the school-based services work, it's work under our 1115 demonstrations, enabling more transitions from incarceration settings supported by Medicaid. And also some of the work that we're doing in health-related social needs, trying to create a no wrong doors approach so that when somebody comes to you needing something, you're able to point them to the resource you need. So those are just some of the examples of some of the things that we've been doing in the Medicaid and CHIP space. And just, I was reflecting just before we came on, actually, as we transition over to my colleague, Jeff, just, in the unwinding setting, I'm a practicing physician, and I was thinking about the patients who I've had who were no longer eligible for Medicaid during this time, who I was able to refer to Marketplace, and what it would have been like for me if I didn't have that to refer them to, that it would have been a very different and much, much worse experience. I was just reflecting on that when I was thinking about all the different things and the kind of collaborations that have happened between different programs to try to sustain access and improve equity.
Thanks, Jess. Another great segue. Seated immediately to my left, Jeff Wu, the acting director for the Center for Consumer Insurance and Oversight, affectionately known as CISO. I might have missed a word in the title there, but Jeff will correct me in a moment. Close, I'm told. But Jeff, your insights on what CISO is up to, and then would love your reflections too on that coordination and collaboration around Medicaid renewals.
Sure. Thank you. Yes, I'm Jeff Wu. I am the acting director at CISO. We run the exchanges, Marketplace, across all of the federal exchange states and then regulate the state-based exchanges. And then we are also CMS's arm into the commercial market, and we regulate the broad employer market along with our colleagues at the Department of Labor and the Department of the Treasury. Our strategy has for a long time focused on enrollment, maximizing enrollment, increasing access to services for those folks who are enrolled, and then building in and increasing consumer protections. That enrollment piece that Jess talked about, a big part of our efforts this past year have been focused on these coverage transitions. And, it is an unfortunate product of our system that we have these very distinct programs, including, if you want to call it a program, sort of employer-sponsored insurance out there. And the transitions between these programs, each of us works very hard to optimize our programs and make them work as best we can for our enrollees. But the transitions between these programs are places where people get lost. This year, we've been focused very, very much on working with our colleagues at CMCS and with all our colleagues in the state exchanges and the state Medicaid agencies to make sure that those transitions are happening as smoothly as possible. And this is not an effort that will end with the conclusion of the unwinding process. I think what it's really done is it's focused our attention on this problem long term, and we're going to be working very hard in the years to come to make sure that process becomes smoother and smoother. I think there are similar transitions between exchange or the commercial market and Medicare in and out of employment-based coverage onto exchanges or into Medicaid that are places where we need to look at very closely in the years to come. And I'm really heartened by the fact that we have been all working so closely together the last couple of years, as well as with our colleagues in the states and in other federal agencies. We've also been leaning very hard into sort of traditional ways of driving up the rate of insurance. We've been investing very heavily into outreach, into navigator programs, navigator grants to get folks enrolled in exchange coverage. We hit our record setting 21.4 million plan selections this past open enrollment cycle, which is just like leaps and bounds above anything that we've ever been able to do. Thank you very much. We're super excited about it. And that really, is a function of leaning hard into getting the word out of the benefits of the Inflation Reduction Act, right? These enhanced subsidies that are such a critical part of getting folks access to coverage. We've also been working very hard on the access to services, particularly in the area of network adequacy. This is something, so we've done a bunch of stuff in this space. Within the federal exchange, we have been working these past number of years on steadily raising the floor on what counts as an adequate network, just using the traditional time distance measures. But we're also implementing this year a new measure based on appointment wait times, which I think is becoming a metric that we're going to be using across all of our programs. And I imagine will start to begin becoming adopted in the employer market as well, as a new and very important way to measure actual access to real services. That is work that is we put out the rules, we put out the guidance, and then there's just a ton of very careful plan by plan discussions and negotiations, looking at maps, looking at statistics, and and negotiating about like, well, look, are you sort of at a level that this is a plan that we can be proud of putting out there for our enrollees, and that's going to be a slow process. That's going to continue for years to come as we continue to look at this issue. But I think it's going to pay off and pay off real dividends to our enrollees. Last point, because I know we have so much to cover. Last point I wanted to cover was around consumer protections and benefits. We have put in rules this year that have made possible the addition of adult dental benefits, for example, into essential health benefits across states. I think that's a very big deal. We have been leaning very hard into work on yes, and that is another area which is tricky because the actual implementation of that benefit is going to require a lot of work around networks, around coding and billing, like these sorts of very mundane but really important operational pieces of the puzzle. But that's work we're looking forward to engaging in. And then I will also sort of say we're continuing to lean very hard into consumer protections and enforcement. We have a lot of benefits and rules on the books, but folks don't always have access to them. The reality is that our system is mediated through private insurance companies, and so the work of enforcement, particularly our enforcement efforts these past couple of years, have been focused on preventive services, around PrEP. I'll call out in particular, around contraceptive services, around mental health services, and around formularies. And that work will certainly continue. Maybe that's a good place to stop.
Thank you so much. Before I move us to our last question, I just want to pause and take a moment to acknowledge how much was just shared across what is a massive agency that serves over 160 million people. I also want to acknowledge if there's anything before I bring us into the home stretch, if there's anything that anybody wanted to add on or share that maybe you forgot to mention. It's okay if not, but I just want to give you the opportunity before I move us to our next question. Okay, we're good. Home stretch here. And I know it's tough after lunch, so thank you all for sticking with us. This year's conference theme is Sustaining Health Equity Through Action. So my question to all of you is a two-part question, really. One is, what are you doing to sustain the incredible work that you've just shared? And two, this audience represents a really diverse cross-section of people working in the social sector, healthcare, public sector, private sector, academia, etc. What would your call to action to the audience be to continue in this work? So two-part question, I'll repeat it again. One, what are you doing to sustain this work? And two, what would your call to action be to folks in the audience to sustain this work? Maybe we'll go, well, we can popcorn. Dora, I'll start with you. Surprise!
It's like I said, popcorn, or back to the end. No, but thank you so much again. I have to say, this has been a very rich discussion, even for me. I'm like, are you doing that? So I'm glad that you were able to get us all in one place, on the stage at one time. For us, when we think about sustainability, in many ways, sometimes when we think about our quality measures, for example, the first quality measure that we may put out in some ways could be like a 1.0, where it's more introducing a topic. Let's see how the community, whichever provider, facility types, how they respond. They will give us feedback, and then the same measure 2.0 will be stronger. It'll be more rigorous. And so for us, we're always building upon the work that we've done, perfecting it, making sure that it's keeping up with what's happening on the outside. And so it's one way that we sustain. But the other, and I was actually just thinking a question, like how many in this room, how many of you have provided comment to one of our regs or rules?
Impressive.
That is most impressive, but not every hand was raised. And so that, I think, is just, if I was thinking about the call to action, what we desperately need comments, both in some cases when it's a request for information, help us keep up to date with the evidence, help us be where we need to be, but also we need your advocacy. We need to be pushed. When the lawyers look at us and say, you can't do that, we can point to the comments and say, now we do. We have logical outgrowth. I've learned a lot of things, legal terms in my time at CMS. But I really just, to the extent you can encourage and work with your partners in the field, work with those smaller organizations or individuals who have not, to really, again, help to provide input through our formal structured opportunities through the rulemaking process. The other, though, and that's, of course, I started with what we need. It's all about us. But really thinking on the outside, we can only, if we put these requirements in place, for example, hospitals to screen for social needs. Many cases we hear hospitals say, we don't know how to do that, or where do we refer? We really, it would be helpful for us if you could help us implement this on the ground to really, if your organizations or your academic institutions or whoever, if you could be the expert or the trusted confidant, the source of information that you could approach, whether the hospital or whatever the right facility type, and provide your expertise and your input, or say, we can help, you can refer to us. This is really just trying to make sure that the requirements are actually meaningful on the ground, being implemented in a way that's sustainable, and that will have a true impact for us, of course, for our beneficiaries, but truly for the communities even more broadly than that. So those are, I think, sustainable and the call to actions.
Thank you. I've abandoned the popcorn idea. Liz.
That's good. I do like popcorn, though. Well, thanks. And this has been such a fun panel. And I agree. I've learned a lot. I didn't know some of my colleagues were working on such interesting things. We don't get a chance to always share what we're doing. So thank you. And so in response to your question, remember, we're the Innovation Center. So our whole purpose is testing things and figuring out how to scale them if they're working. So this question really speaks to our whole mission. And so we are really thinking about how we can leverage what we're learning into the rest of the program, into Medicare and Medicaid. I'll give a couple of examples. Our Medicare Advantage VBID, or Value-Based Insurance Design program, we hope is informing Meena's program in Medicare Advantage. Starting in 2025, we learned that you can target benefits to those who need it most. And starting in 2025, those plans that participate in our model will be required to cover 2 out of 3 social services or social aspects that address health-related social needs. They've either got to choose housing, transportation, or food and insecurity. They've got to cover 2. And so what can we learn from that might be informing Meena's programs? I think another example is the Accountable Health Communities model, very successful model that really launched a lot of our work in screening for health-related social needs. First of all, the tool that we developed as part of that model is now used across a lot of our programs. It's the screening tool that we are using for HRSNs. And I think part of what we're learning is that you can screen and scale on a very large foundation, screening for health-related social needs, referring for community services, and helping patients navigate it to be able to meet those needs. And we're hoping that we can take some of those learnings as well. And then maybe just one last example, the ACO investment model, another model where we found that if you provide incentives to smaller rural community organizations and practices that want to be part of an ACO, if you give them those tools and incentives and resources, they'll be able to come into the program and really provide that person-centered care that we're seeking. And that program was made into a permanent part of the Medicare program. So this is all to exactly, you're speaking our language, and exactly what can we do to further what we're doing. In terms of the call to action, these programs and what we're learning should be extended across our health system, private insurance, commercial insurers, employers. There's a lot of what we're learning. And so I think helping us get the word out there and spreading that would be very helpful. I think, another angle, we're learning that not all providers want to screen for health-related social needs, that sometimes they feel like asking those questions is uncomfortable. Helping people get comfortable with asking those questions and meeting those patient needs, because we are learning that it actually does reduce emergency department use. It reduces unnecessary hospitalization. So whatever we can do to get the word out that these are initiatives, strategies, approaches that can really improve patient care overall.
Thanks, Liz. Meena?
Great. So I'll build off of what both Liz and Dora have said. In terms of the sustainability, Liz gave some examples of how we are working closely with the Innovation Center, where there are ideas that they have tested around equity that we are now incorporating into the Medicare program to create that sustainability. I think that also holds true for when we are building new programs. Tim called me out for not mentioning the Inflation Reduction Act, so now I will.
You got so much stuff.
I know, there's so
impossible.
much. I was only allowed 3 examples.
Oh, I'm sorry. Sorry.
It
was really 2, and you took a third. Yeah.
Fair point. So, as you may know, we are currently negotiating the first 10 drugs selected for the Medicare Drug Price Negotiation Program. And importantly, when we put out the guidance to set this program up, we embedded equity into the negotiation program, where we specifically said that we wanted to look at how these drugs address unmet needs in our communities, how they address the needs of specific populations, how are they used in the real world outside of a randomized control trial, because I don't think any of us live life like a randomized control trial. And that's where the caregiver angle comes in as well. So where we are, part of sustainability is embedding equity into everything that we do day to day, so that it becomes just part of the lifeblood of all of the programs that we run. And I think that comes to the call to action as well. Again, to build on what some others have said, it's really great that we, put out a policy. We can put out a 2,000-page payment regulation in the Federal Register and declare victory. It can have very little impact. It really comes down to not only all of you giving us ideas of where you see the opportunities to address equity, then when we giving us comments on the policy, when we finalize a policy, really making sure that it comes to life. And this comes to, what Tim mentioned, that the low-income subsidy extra help program in Part D, we estimated that there are 3 million people who are eligible for this program and not enrolled. So we have expanded eligibility thanks to the Inflation Reduction Act, and that's not enough. We need all of you. We need trusted community partners out there educating people, like telling them there is this available, helping them to enroll. And it's that last mile that really is what will make a difference ultimately for our communities. So, the call to action would be both continuing to give us ideas, your perspectives, and then really partnering on the implementation of these. And, to that point, you may have seen that we put out our draft guidance for the next round of drug negotiation. And incorporating the voice of people taking these medications is very, very important to us. It's important to me as a physician. And we have asked for comment on how we had these 10 patient-focused sessions for each of the drugs, and we're asking for comment on how that went. Are there other things we should be thinking about? How can we make sure that we are hearing from the diversity of populations that are impacted by these drugs and that are impacted by the work we're doing? So that's a very specific call to action.
Amen on all that. It's a volume of stuff is represented everywhere here is like mind-blowing, but we totally like unrepresented on this stage are the state officials, and I'm thinking of the state Medicaid directors who also have like mind-boggling complex jobs right now. And so I think of them, but I also think of the challenge for us to do two things federally. One is make our policy simple and understandable and clear for the states to meaningfully effectuate them. And second, it's so hard for all of us, simplifying the actual mechanics of how beneficiaries experience our programs. I talked about it in one context, just making it easier to apply for certain programs, doing it for the Medicare savings programs, but also the rest of the Medicaid program writ large. Jeff talked about it in the context of taking some of the friction out for those transition points between different form of coverage, which almost assuredly differentially affect people with low health literacy, people who don't speak English as their native. I mean, you can easily see the equity underpinnings of like simplifying some of these processes, but they also make them more sustainable too. I mean, the rule I talked about is actually like letting states do less work. Right. And hopefully that will be inherently more sustainable than our other policies that make everybody do much more and more complicated work. So I think it's a challenge we all share, which is like, how can we take friction out and how can we simplify the experience that people have interacting with these different programs?
Thanks, Tim. That's a great segue, as usual, for what I was thinking about in terms of partnership. So we are completely committed to embedding health equity in everything we do, just as Meena was saying. And, as part of that strategy towards continuing to improve access to high quality whole person care. But there's no one provider or organization or program that can actually do all of that by themselves. It has to actually be a collaboration. And in some cases, collaboration between people who haven't worked together before. In the case of health-related social needs, it's bringing in new people who are experienced, trusted community providers and who are experts in topics like food and housing security, and having them work with Medicaid programs and the healthcare system in a way that they haven't before. And so thinking about these partnerships, making partnerships not just a word, not just calling someone a partner, but actually building a true, meaningful collaboration. And that's what I would leave as my call, to do that today, potentially, whether you're here in person, meeting someone you don't know before, reaching out to somebody who you think could be an interesting new collaboration, or thinking about how to make an ongoing collaboration more meaningful. Because that's one of the things that we're thinking about a lot as we try to bridge a lot of the different silos in trying to improve care and equity across the spectrum.
So I want to start with something I did forget to mention last time, which I definitely want to mention, which is one of our proudest achievements at CSIO this past year, is that we issued a final rule opening up the marketplaces to DACA recipients, and that was a rule a long time coming, and that we believe will result in 100,000 DACA recipients getting a coverage that they previously did not have. So we're very excited about that. But so I think of this question in sort of two fronts. One is sort of the big, like very public rulemaking process. And for sure we have an ambitious agenda, as all my friends and colleagues up here have, over the next short period of time. And I'll just sort of flag that we have a very complicated rule on mental health parity that we are working through right now that's going to have pretty sweeping implications across all of our programs, across the ESI market as well. That's a huge focus of ours. I can see coming up on the horizon, I think we're going to really do some ambitious work in the preventive services area, rulemaking to sort of clean up a lot of the continuing frictions in that space. And in that area, I would very much continue to ask for your advocacy and for your thoughts, for your comments, and for working with us in the implementation of those rules. But what I touched on before is sort of this long-term, very down-in-the-weeds operational implementation of these programs. And I think that's where I would really ask for your help. When we dug into, so we have issued round after round of rules and guidance around preventive services for years now. And we continue to get complaints. It is apparent that it's not really working. And we had a number of meetings with advocates, and some of the advocates said, you need to really issue another, like more sternly worded piece of guidance, and go after these insurance companies. And there is value to that. But where I thought the real value of the meeting came was when we started talking this is a meeting about PrEP, providers of PrEP and the difficulties they had in getting the different insurance companies to recognize what they were trying to code. And we realized that a lot of the problem here had to do with sort of very widely varying operational processes happening in each of these systems because of the fragmentation of our system, because of the way our health system works. And coming out of that meeting, our strategy shifted very significantly on that particular issue. And it went to one that is going to focus on coding, that is going to focus on sort of using the bully pulpit and bringing together executives at insurance companies to agree to a common set of standards, a common process for getting those kinds of services, making them available. And so my ask on that front is for your engagement at that very operational detail level, engagement with us, engagement in those problems, and helping us understand sort of what is really happening and where the frictions really are. Because sometimes the solution isn't a big sweeping rule in the Federal Register. Sometimes the solution is, hey, how do we get our system to work better? And how can we take our sort of market power in our bully pulpit and nudge the system in that direction? And so I would ask that of all of you. I have found those interactions to be very enlightening and very helpful.
Thank you so much. Two themes I want to reflect on as we close. One is I hope what you're hearing and seeing and feeling is CMS is not a monolith. It's in fact made up of people and teams of people that really care and share a mission that I think many in this room and watching virtually share, which is to do right by and serve people and communities. The second thing that I hope you're taking away is one of my favorite phrases, which is health equity is a team sport. No one up here thinks that we can do this alone, and we realize that there is a real power in the community and diversity of people represented in this room and people not represented in this room. So please continue to make your voices heard, continue to engage with us, challenge us, hold us accountable. So that's really how this work advances. With that, I hope you will join me in thanking our panelists today for their time. We're headed now into a 15-minute break. Take it back. You're free till 2:30, and then the breakout sessions start. Thanks again. Enjoy the rest of your afternoon.